I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thanks for joining us for today's procedure. Our guests are Doctors Teresa Diaz-Montes and Beman Khulpateea, both gynecologic oncologists at Mercy. Dr. Diaz-Montes, you earned your bachelor's in biology and your medical degree at the University of Puerto Rico. That's where you're from originally, correct?
Yes, I'm from San Juan.
Okay. Now, how did you wind up here in Baltimore?
Well, because at some point in my career, I wanted to become a GYN oncologist. And in Puerto Rico, they don't do the training in GYN oncology. So you have to leave the island and to come here to the United States for training. And we can do all the training in GYN. That's what I did my residency in the University of Puerto Rico Tertiary Center. And then I came back here with the plan of staying for 3 years. And now it's been 20.
Did you always want to go into GYN oncology?
I did not. I wanted to be a generalist, a general OB/GYN. But during my third year rotation, I met a patient and she changed my life. She had uterine cancer and she didn't trust anybody. And she came to the office very, very scared. And then I have to calm her down. But by default, then I became her doctor. So I have to see her every time that she came to the office for follow-up. So it doesn't matter in which clinic I was in the hospital, I have to leave whatever I was doing to see her. And that's what my first engagement with GYN oncology. And then I realized that I really liked that field because thinking backwards, when I was at that point in my career, I always loved pathology. I loved geriatrics. I love medical oncology. Those were my options before I decided to become an OB/GYN. And then GYN oncology mixed all of them. So she opened me the eyes because I was so afraid of the field. I was like, I don't want to be talking about dying and being a sad field, but it's not. And then she made me open my eyes that this is a possibility for me, and that's how it ended up. So I came to do my fellowship here, and I still had a relationship with her there. So every time that I flew back home, I had to stop in her house because if not, she will get very angry if I didn't see her. Unfortunately, she passed, after, she was old when I first met her. But, it was she was the one who had me where I am here. So if it was not for her, if I didn't met her when I was a resident, I would never be here. Mm-hmm.
Now, Dr. Khulpateea, you earned your Bachelor of Arts degree from the Hopkins Zanville Krieger School of Arts and Sciences. And that focuses on humanities, natural sciences, social sciences, and the arts. Now, what moved you specifically from that into medicine?
So my degree was actually in public health. And so I initially kind of had a different view of healthcare, sort of like a zoomed out view in terms of kind of how to approach the healthcare system. But sort of as I kind of went along and then learned more about the biology and kind of how the human body works, I kind of got drawn back into that side. And I sort of have a predisposition towards that. Both of my parents are physicians. So that was kind of in my mind as I was going through, my education.
So you had some background in public health, you as well, correct?
Mm-hmm. Yes.
You studied at Hopkins for that, and you at Yale University.
Yeah.
Now, this is interesting to me because there was a report from the Trust for America's Health that revealed during our recent pandemic, showed that there was a national public health network that had been hollowed out by years of underfunding and neglect. Given your backgrounds in public health, why, in your opinion, is having a strong, supported system of public health important, particularly, with the lessons that we've gotten from COVID?
Well, I think it sort of exposed that the United States healthcare system really does have a lot of gaps. I mean, there's people who don't seek care regularly, whether that's due to cost or due to access, and where there are people who, kind of don't have good infrastructure for follow-up. And I think that's sort of things that were brought to attention with the COVID pandemic, when people kind of were getting sick and just showing up to the emergency rooms, or even more worrisome in some ways, not showing up because they're scared of going to the emergency rooms, where people who have established doctors kind of were able to get plugged into the system well and sort of triaged well and treated more efficiently.
No, I agree with Beman on that one. And also, I think having a strong public health system is important in a sense of communication too. I think one thing that COVID brought during this pandemic was the lack of communication or misinformation. And that dives very deeply into patients, because patients listen and they trust. And when you have multiple people giving you multiple information, and people who call themselves experts and may not necessarily have the experience, then that leads to people being more afraid or not able to seek care. And we are, I think, I don't know if you agree with that, I think we're seeing now the year and a half of pandemic that we live, and people not coming to the physician's offices and to the hospital. We are seeing it now, the results, of people having presented with cancer when they could have been detected earlier. Now they are at a later stage. I was asking myself when we're going to see that point, and I think we're seeing it now.
As they say, it's, during COVID, it wasn't like all the other diseases went away. But as you mentioned, both of you mentioned, getting people willing to come down to a hospital or to see a doctor during that difficult time, it's really, just really made a bad situation worse. Fortunately, things seem to be getting a little bit better now. So have you seen an increase in patients now recently, seeing more that maybe were coming in now versus before?
Yeah, I think yes. I think people are starting to come out of the shell and decided to come to see us for their follow-ups. There's still people who are concerned, about COVID, and they ask, like about the vaccine, about if they're going to get the next vaccine. They just keep asking all those questions. But definitely they're more open than before and not as afraid.
We'll take a break and we'll be back for our next segment of Medoscopy.
For me, as a gynecologic oncologist, I think some of the most important areas of research and innovation really have to do with minimally invasive surgery. We can shrink the cancer down with some chemotherapy. You can actually go in without those big cuts, just a few tiny holes, and have it performed laparoscopically, robotically. The patients go home the next day. To me, that's very, very exciting.
Depending on where you're looking in our field, there are advances going on all the time. You have your standard chemotherapies, and then you have personalized medicine, and now immunotherapy, where we're actually using the body's own immune system to try to tackle these cancers.
One of the things that it's really exciting that we can offer here at Mercy is something called heated intraperitoneal chemotherapy. At the time of the big surgery, when people have to have the ovarian cancer removed, we directly treat it with chemotherapy into the abdomen.
And the patients, of course, are going to need to get adjuvant chemotherapy, but it's better, well tolerated, and better able to complete the treatment than what is being described with intraperitoneal chemotherapy.
I always see medicine and surgery as only a part of the equation of well-being. It really is more of a philosophical approach to get that individual to really buy into the positive outlook we see for her.
Patient is obviously the most vital part of healthcare, and it's making sure that the patients are both aware of what is happening to them, what they're going to undergo, and that they stay as well informed as we can make them.
Even we're very, very specialized, and we are in the vanguard of a lot of the treatments. Mercy provides me the opportunity to establish a relationship with a patient where it's more like a one-on-one direct.
Everyone has that same focus on the patient and what we do and how we're going forward, and also taking the patient and their point of view and their desires into our plans.
I will give all my patients all the options, the data behind each option, and then let them decide. But a lot of the times we'll say, well, what do you think? So it's really a team effort.
Patient-centered care to me means a devotion to the well-being of the patient, not only focusing on state-of-the-art medicine, but our overall well-being so that we can get an optimal result from our treatment.
As frequent viewers know, one regular feature of our program is a sort of show and tell, where guests bring in something, some item, could be a book, could be a photograph, who knows what, but is in some way important to them, symbolic of who they are and what they're about. Dr. Khulpateea, let's start with you. What have you brought with you today?
So, as a doctor, we're in a position where I think we're lucky that we get a lot of feedback from the people we work with. And so patients very often will give us little notes or thank yous or gifts. And so this is a note that a patient gave me that I keep on my desk, actually, to remind me a little bit. What we do, we do a lot of surgeries, and I feel like we gain satisfaction. I feel like we physically take care of our patients in that way. But this was a really kind note from a patient that it was very different. She came and saw me, and I didn't take care of her myself. It wasn't something that I necessarily take care of, but she bounced around from a few doctors. And she wrote in this note, she said, "I cannot remember the last time a professional treated me with care, did not rush, and ensure I felt heard and supported." And she felt so strongly about that she wrote me a letter, in spite of the fact that I was not the doctor who ended up taking care of what was making her sick. And so I keep that there to remind me that even when things are sort of busy, that we need to take care of these people because they're here for that reason.
Doctor?
Well, I brought something that is very deep into my heart. So my family, I don't come from a family of physicians. My dad is an engineer, a retired engineer, and my mom is she was a teacher. I think I ended up being in the medical field because my dad was a biomedical engineer by career, and I run into all the basements of the hospital. So I gravitate to basements all the time because that's where I feel comfortable. If you go to any hospital, you will know that the Department of Engineering is always on the basement, next to the janitor department, and the morgue. So my mom came from a family of 6. All of them were girls with the exception of one. My grandfather was a farmer. He never went to school. His dad pulled him out of school because he has to work in the land. And he made himself, I think he struggled not having an education, that he told all my aunts that they will not let them get married until they went to college. And he kept that promise. And if anybody wants to get married, they have to show their diploma, and then they will allow them to get married. And they were from a very little town in the center of Puerto Rico. So it's very unusual. My grandmother never finished school either. So she went to school when she was an adult. And I tutored her. When I was in high school, I tutored my grandmother, so she finished her high school diploma. When she passed, several years ago, my mom gave me her diploma. So this is what I have, her high school diploma, because I helped her finishing her high school, and she was so proud. So I learned from my parents that education, they told me they will never be able to leave me money or properties, but an education was very important. And that with an education, I could pursue my future. And that's the legacy that I want to leave with my children too. And that started with my grandfather. So he ended up leaving 6 children, all with education that they passed out to all the other generations. And so far, all my cousins, they finished college, and everybody was being able to pursue a career. So I don't know, it's just for me, like helping my grandmother reach that. It was like a big, big thing. So I just keep it close to my heart.
Dr. Diaz-Montes, I know you've been involved in some pretty intriguing research concerning the treatment of ovarian cancer involving HIPEC. Mm-hmm. That's the hyperthermic intraperitoneal chemotherapy, or heated chemo. Mm-hmm. Now, what are you and your colleagues discovering with that?
So we're just trying to look for alternatives in terms of the traditional treatment that is available for ovarian cancer, better ways of administration of treatment. So patients have a better response to what we actually have. They have a better quality of life, a longer survival, because as we all know, ovarian cancer still, despite all the interventions that we do, people could have not a good outcome. So that's what we are looking for. Recently we presented our data about quality of life in one of the big meetings in March in Tampa, in the Society of GYN Oncology meeting. We were super excited because it was the first time that we were actually given a podium, Mercy, presenting our data. And we were just showing that HIPEC is not as bad as people think, that people really have a great quality of life, that patients do well. that patients can do whatever they want, after they heal from the procedure. So it was like really exciting to be able to share that with the other providers, and then just break the myth about HIPEC.
Now that they're finding that heated chemotherapy just is much more effective than the standard IV therapy, at least in these particular cases. So that must be very gratifying to see that.
Yeah, it is. And actually, we talk all the time about HIPEC and ovarian cancer, but at Mercy, we do HIPEC for rare malignancies. So it's not just ovarian cancer. We have published about our experience of HIPEC on leiomyosarcomas. Those are uterine cancers, very rare. We have recently published about our experience in carcinosarcomas of the ovaries. That's another rare type of cancer. So we use HIPEC in different scenarios, and we keep publishing all our data. Now, the latest thing that I'm focusing on is just not the treatment of HIPEC and ovarian cancer and survival. I'm looking more at outcomes and patients experiencing. So we are now doing, in females, we're doing a sexual functioning study. That's what I'm focusing on, because we talk about surgery, about side effects, about complications, about risk, but we never talk about how do I feel, how this is affecting my life, how it's affecting my relationship with my husband, or how this is affecting me, like how I can perform. Like, we don't talk about that. And that's what my goal with working with Dr. Sardi and his team is, to push the boundaries on that type of topics that they are never discussed.